Hello and welcome everyone to today's webinar, NAVIFY Tumor Board Demonstration and Live Multidisciplinary Care Team Question and Answer. My name is Denise Heaney and I'm a Senior Scientific Affairs Manager supporting Roche Diagnostics Information Solutions. I'd like to extend a thank you to all for taking the time and joining us here today. As the COVID-19 pandemic continues, we strive to provide the best health care for those suffering from cancer. As we all know, cancer care doesn't stop, even though we are in these unique, unprecedented times. In our last webinar, we discussed the value of virtual care for oncology patients by sharing examples of driving that virtual care, specifically with tumor boards or multidisciplinary team meetings. Today's webinar, we want to focus further on that multidisciplinary meeting within cancer care and how the approach to these meetings has changed or adapted in the current situation, as well as what the future will hold for oncology care. The discussion will progress from the preparation of the multidisciplinary care meeting to the case discussion of a patient and follow-up with insight provided from our key opinion leader panel. At the end of the webinar, we will have a live question and answer with our panel. Throughout the webinar, please submit your questions in the right-hand corner box where it says Submit Questions. Part of today's presentation will include a demonstration of NAVIFY Tumor Board solution. The patient we will be using for this demonstration is a fictitious patient used only for this demo purpose. This patient is Jane Krin. She's a 43-year-old female patient with breast cancer. We will see her oncology journey displayed in the NAVIFY Tumor Board throughout the webinar. It is with pleasure that I introduce our panel today. Dr. Adam Dicker, Enterprise Senior Vice President, Professor and Chair of Radiation Oncology at Thomas Jefferson, and the Director for Jefferson Center for Digital Health and Data Science. Also joining us is Dr. Richard Hammer, Vice Chair of Clinical Affairs and Pathology and Anatomical Sciences at the University of Missouri. And finally joining us today on our panel is Janie Connor, registered nurse and senior application specialist within the Roche NAVIFY implementation team. Before we get into the demo, we were going to have a few questions from our panel, and I'm going to start with those. So Dr. Dicker, for quite some time, the value of multidisciplinary teams has been demonstrated and for the most part has become the standard of practice for oncology care. During this time of the pandemic, you have had to do things differently to continue to deliver and optimize care for your patients. And I know some of that has included transitioning to a more virtual approach. What have you and other healthcare providers learned from this? And in addition to this, what has the patient expectation changed also during this time as well?
Yeah, thank you, and thank you for the opportunity to participate today. We've learned a couple of things. We learned that there were some myths as it related to new ways of delivering healthcare. You know, before COVID-19, there were myths about patients wouldn't be interested in telehealth. There were myths about how can you do this? There were myths about would it be the same quality of care? There were myths about how providers could work with each other in such a setting. And I think what has radically changed in the past 2 to 3 months, depending on where you live, is that all these myths have been shattered. So we have been able to deliver care effectively. We did it seamlessly. And you'll hear about Dr. Hammer's experience at the University of Missouri. Patients' expectations actually have gone up, whereas before, when they came to a bricks and mortar waiting room, they may have waited and tolerated that waiting. In a telehealth environment, there's an expectation that that provider will be timely. It has provided some challenges. As you know, clinical trials throughout the world have been affected by COVID. So we've had to prioritize our trials. So this does affect what we would recommend at a tumor board. And the final thing I'll mention is that there were new data streams that we didn't fully appreciate before that relates to COVID, the testing status of the patient, comorbid conditions that put them at risk, in addition for a cancer diagnosis for a moderate to severe COVID. So I would say it's been an interesting experience. I would not like to relive it, but I think those organizations that were ahead of the curve, whether it be in clinical decision supports and tumor boards or telehealth or all the above, had a better adaptability to this crisis.
Excellent, excellent. Thank you, Dr. Dicker. So, Dr. Hammer, like shifting into the multidisciplinary care team meeting at your institution, University of Missouri, you have implemented NAVIFY Tumor Board solution. Before implementing the digital solution, you all conducted a value mapping exercise to look at tumor board meetings to really gain a better and broader understanding of those constant and variable factors that relate to not only preparation, but also conduction of the multidisciplinary care team meetings. Can you share with us what some of those key findings were from this assessment that you all did?
Yeah, sure, I'd be glad to. So NAVIFY was co-developed here with Roche at the University of Missouri. And one of the first things we did actually was to just take a high level look at tumor boards and see what kind of things would we like, what kind of things would we like to produce in a clinical decision support software to streamline and make tumor boards better than they are already. So the first thing we did was do a sort of value mapping process. And tumor boards are quite complicated. It takes a lot of effort and time to pull things together. There's a lot of information that needs to be collated, and then it needs to be put into a presentable format. So one of the first things we wanted to do is provide easy access to all of the results that we might need to discuss at a tumor board, and then put it into a single presentation platform to avoid people preparing multiple different presentations. And that in itself would deliver a better product that could be unified and give us a more efficient tumor board. Another thing that we would like would be automatic integration of much of this information from our EMR so that we did not have to go find it manually. And then we also wanted something that would improve our workflow efficiency and standardize our tumor boards. Everything here was done in a manual way, and there were a lot of different ways things were being done. Last thing we would like to really do is be able to capture and implement the tumor board decisions and have it in a format that was easily retrievable and that we could use to monitor and make sure that we follow through on some of the decisions that are made during the tumor boards. And I think we captured all of this within the development of where NAVIFY is now in its integration with the EMR in its latest version of the software. And this has vastly changed the way we do tumor boards, and we'll talk more about that in the end. But by having NAVIFY already implemented here, we were really just ready to flip the switch, if you would, and take this to a virtual environment. We had already been planning to do this, and of course the COVID crisis has sort of compelled us to move quicker. In fact, we were so ready, it really only took me about 4 hours to go live into a virtual environment with our first tumor board.
Excellent, excellent. Thank you, thank you. So it's interesting to hear how, from both of your perspectives, how the pandemic has changed your approach in terms of virtual meetings. So let's move to preparation for the tumor board discussion. So when we prepare for a tumor board, as you mentioned, Dr. Hammer, it's no easy task. There's, depending on your role or specialty, you still have to gather information, data, and there's prep time associated that. I assume whether or not you are holding a meeting in person or virtually, this doesn't really change the preparation that's required. And so I'm just curious, Dr. Hammer, what do you do to prepare for your virtual tumor boards that you're holding now? And has that changed since you've since the pandemic and you've been only holding virtual tumor boards?
Yeah. And so as you suggested, there's a lot of information and a lot of effort that goes into preparing our tumor boards. And one of the things, that we need to do, we still do, is we prepare our tumor boards essentially the same way that we did prior to going virtual. What we have found, though, is that using NAVIFY has provided some level of standardization, made it easier to access the correct data because much of it's now integrated within our EMR, and it's provided some efficiency for us. However, the actual preparation between being live and being virtual is essentially identical. We just are now presenting things in a virtual environment. In fact, looking at a study that we did, which is coming up on the next slide, will show that, by using NAVIFY, we've actually really improved the efficiency of our tumor boards by saving our nurse navigator who prepares our tumor boards and saving time. So we showed a 64% reduction in her preparation time prior to NAVIFY and then after implementation of NAVIFY. And this was in a live environment. The transition to the virtual environment, as I said before, was very simple for us because we were essentially already there.
Excellent. So Dr. Dicker, from your perspective as a radiation oncologist, what are the key things that you do to prepare for your tumor board, and has that changed for you since the pandemic?
Yeah, so again, I want to amplify what Dr. Hammer said. I think the way not to prepare is to have a lot of paper flowing back and forth about a patient and the trials, etc. I think having a unified system to present the information, there's always concerns about private health information and how you're sharing that. So it's always better to have a one platform. I think, in the way I prepare, I'm certainly ready to present my patients in terms of the background information, social determinants of health. What was my thinking in terms of, what I was presenting to the patient. I'm certainly interested in other pieces of information. We, like the University of Missouri, are heavy proponents of precision medicine and using genomic classifiers and other types of molecular studies, and how that information is brought in to a platform like NAVIFY, or how it's not brought in terms of a PDF is obviously always a concern. And I think COVID-19 has brought up a new issue about innate immunity, and I anticipate that for oncology patients, that's going to be another issue as well, and another data stream. But we spent a lot of time kind of prepping, and the other respective specialist, the radiologist is reviewing what they may have reviewed either very recently or a week ago. Pathologists are kind of manually, in a manual system, they would remember or mark on a slide what areas they want to highlight. So I think there is a fair bit amount of prep time. And just to Dr. Hammer's point about reducing the nurse navigator's time, that allows the nurse navigator to spend more time with the patient, because it's exceedingly time consuming to interact with patients. They're sharing their information. He or she is trying to collate that information, trying to reduce the anxiety the patient has, and present it or help coordinate and aggregate the information so that these specialists can help provide the highest level opinion during that tumor board interaction.
Thank you. Thank you both very much for that insight. It seems that regardless of whether the tumor board meeting is in person or virtually, that preparation and collection of data is part of that process, and that having a means like a digital solution that collects the data, assists in bringing it all together. And to your point, Dr. Dicker, allows for more time to be spent on patient-focused activities versus the collection of data. So Janie will now walk us through the preparation of Jane Kren's patient case to prepare for the upcoming virtual tumor board. And again, I just want to remind everyone, if you have a question, please put the question in the submit a question for us, and we will have Q&A at the end. So Janie, it's all yours.
Thanks, Dr. Heaney. So when it comes time to prepare for virtual tumor board, roles may be changing. Every site is different. So I'll be sharing what NAVIFY looks like overall. But with prepping for a virtual tumor board, things may work differently for your site. Today, I'll play the role of a nurse navigator, or it could be a tumor registrar or a pathology resident. Basically, anyone preparing the data and information for tumor board. But there are many specialties involved, and whether it's an oncologist or a pathologist, they can also come in and access this data at any time as part of their preparation. Once logged into NAVIFY, you'll see the landing page, and there are 3 separate tabs: tumor boards, patients, and apps. When a tumor board coordinator is creating a tumor board, they will click on the words Create New to complete the first 5 fields and build a tumor board. But I'll just click Edit so you can see what it looks like when completed. So you would complete the name of your tumor board, the date, the start and end time, and the location, of course, would be virtual. The video call field is an optional field available to include your site's video conferencing information. And then you have additional notes if needed, and you can record your attendees in the attendee field. Now, when you're preparing for tumor board, you can see your list of patients here, and you have the option of removing a patient from the list if a doctor's changed their mind, or you can change the order of your presentation. You can also add a patient from here. Editing and viewing a presentation are options, and I'll go through those later with you. And then print list. In today's world, we would probably print this as a PDF and email it to our tumor board participants, but you can also print it to paper. You can look at past tumor boards and see which patients were presented, what was the discussion point, and what were the next steps that were documented. The next tab is the patient tab. And on the main screen, you'll see all the patients that are registered within NAVIFY. If you're subscribed to an integrated version, then patients seen here are added by integration. NAVIFY is software agnostic, meaning we have the ability to integrate with any EMR. You can also manually add a new patient, and to do that, you simply click Create Patient and complete the 5 fields. Once you've created a patient, now you're able to go in and edit that patient and work with that patient on the patient page. The advantage of a clinical decision support tool such as NAVIFY is that you can approach virtual tumor board prep with a mindset of standardization. And that's what you should keep in mind when you're looking at the cancer info page, the patient history, or the timeline. Information on the cancer info screen is the patient summary, the stage with TNM, biomarkers, tumor information, genomics, and treatment history. To help with this standard approach to tumor board, the patient summary, stage, and tumor type will appear on the patient cover slide at tumor board. Keep in mind that many of these fields can be integrated from your EMR, and it allows for one comprehensive dashboard. The patient history screen is a summary of the patient's medical history. Remember, the only data you want included here is what's important for tumor board discussion. Too much information will distract from the conference. Now, on the right side of the screen, you'll see timeline events. Timeline events can be created automatically, like when you create and add a patient to a tumor board. Other timeline events, such as pathology or radiology, can be automatically created if your version of tumor board is integrated with your institution's EMR. Events can also be created manually with this function. The timeline items can be sorted by source type for easy viewing. As you're preparing for Tumor Board, you'll want to review each item and be sure that all relevant information is included. Now you're ready to submit your patient to Tumor Board. Simply click Submit to Tumor Board and complete the fields. After submitting to Tumor Board, you can pin any specific patient information to an upcoming Tumor Board to highlight the information to discuss. Not all information on the patient page may be relevant to present at Tumor Board. That's why you pin it to talk about specific items. Now let's move on to the apps that are built into NAVIFY. The clinical trial match application queries molecular match with key data elements from the cancer info page. The goal is intended to help match patients with potentially appropriate clinical trials. When the search results are displayed, the criteria that led to that match are listed directly under the search box. You can also add additional search terms here, and you can further refine your search with the filters on the right side of the screen. Trials can also be pinned in the same manner as I explained earlier. The publication search application also queries molecular match with key data elements from the cancer info page. The goal is to provide information to help match patients with potentially appropriate publications to discuss. You'll also see the criteria that led to the matches, where you can add additional search terms, and you can further refine results on the right side of the screen. Pinning is also available, as I explained before. And then we have guidelines. The NAVIFY guidelines application is intended to display NCCN guidelines in a digital format. You would use the drop-down to choose your cancer type and then also your starting point. Once the selections are made, you will continue to follow the guidelines interactive decision tree and choose where you would want the path to flow. Treatment paths can be displayed in step view or tree view. Once you've chosen your tree view or step view, if the patient's case has deviated from the guidelines, you can choose the personalized pathway and capture those decisions here. You would describe the altered treatment, select all the reasons that apply, select the next step, and submit. In this case, I'll hit cancel. If you want to present this patient's treatment path during Tumor Board, then you would pin it, as I explained earlier. Some people choose to complete the guidelines prior to Tumor Board, while others document the recommended path either during or after Tumor Board. It's user preference. Now that you've pinned all the important items for Tumor Board, let's take a look at it. Click on the Tumor Board tab, be sure you've chosen the correct Tumor Board, and then hit Edit Presentation. From here, you can choose the patient you'd like to edit, review the slides that you have pinned, and then you can also rearrange slides. You can click on the X to remove a slide, or you can add slides on the fly. Areas of a slide can also be masked by clicking this tool, so you can hide important PHI if you don't want to share that at Tumor Board. Now that your patient is all prepped for Tumor Board, let's return to the panel.
Great. Thank you so much, Janie, for showing us how we can use NAVIFY Tumor Board solution to prepare for our multidisciplinary care team meeting. So the next step is actually a patient case discussion. But before we get to that, we want to talk a little to our panel's members here. And how these case discussions proceed, as we heard, is not necessarily standardized from institution to institution. And in some cases, not even the same within an institution. As we know, some multidisciplinary teams have been around longer than others, perhaps are more standardized and have a set process. So Dr. Hammer, as you've implemented NAVIFY as a digital solution for your multidisciplinary team meetings, what are some of the changes you've seen in terms of case discussion? Have you seen more of a standardized approach occur here? And has this changed at all with the virtual approach you are now utilizing?
So as you suggested prior to us implementing NAVIFY, every department and every service and every specialty kind of conducted their own tumor board in whatever fashion they deemed necessary and appropriate, and there was not really any level of standardization. When we implemented NAVIFY, we also started a 2-year clinical study to see what the impact of using a clinical decision support software would be on the tumor boards. And we collected data for almost 2 years, and we're in the process of publishing that right now. As you can see on this slide, though, this is some of the data. And this is data from our breast multidisciplinary tumor board, which is an accredited tumor board. So it was already a very efficient and well-run tumor board, but you can see that after we implemented NAVIFY, we, in addition to showing the reduction in the nurse navigator time we already talked about, we also showed efficiency in case discussion time and improved the efficiency of the case discussion by about 20% in this tumor board. And this is already a very well-run tumor board. Some of the other ones, again, were a little less organized. And what we saw as we implemented it across the system was that everything became a little more standardized, and everything started to sort of run in the same fashion. So by implementing it across tumor boards in different specialties and different areas, we actually did show some standardization in the approach to tumor boards and some decreased variability in how tumor boards are performed. Now, this was all done while we were still in the environment of doing live tumor boards, and this change has persisted into the virtual environment. We really don't see any difference now in the level of standardization and the efficiency in tumor boards from a live format to a virtual format. And the transition to a virtual format was very, very simple. In fact, many of our clinicians have already emailed me and say, we like this so much, we don't want to go back. And that's pretty much a guarantee. We're not going back. When we do get to the point of when we can gather in a conference room again, we will still continue to offer virtual access to tumor boards going forward.
Excellent. Thank you, Dr. Hammer. So Dr. Dicker, what have you seen in regards to, so I know that there's a large number of multidisciplinary care team meetings at Thomas Jefferson. So what have you seen in regards to standardization across those, and has that at all changed in your virtual approach?
Yeah, thank you. So we're not, there's certain aspects of our operation where we're not at the level of the University of Missouri. And I think COVID-19 and moving to a virtual format really highlighted and exacerbated in some ways some of the challenges. So I'll separate this into 2 parts. I think Dr. Hammer really commented about the structural aspect. So having a clinical decision support that allows you to data aggregate, display information in a uniform way, facilitate discussion, reduce the amount of time for being able to accumulate and aggregate and curate that information, definitely is a structural issue, and platforms like NAVIFY are incredibly helpful. I think it also highlighted human factors issues. So there's no senior oncologist or pathologist or radiologist who's, quote, running a tumor board that got training in how to do it. They saw some successful examples. They may have seen some examples which are, quote, less successful. And I think there's an opportunity on the human factor side to improve that, both at our location and many other locations throughout the world. I think what you're seeing in multidisciplinary care is really team science on some level. And I think what Google and many other technology companies have demonstrated is that some teams are more effective than other teams. And how do you improve that, those teams in terms of how they work together? So having a moderator who's inclusive, doesn't allow anyone to dominate the conversation, showing emotional intelligence, making sure there's a very preferably lively and thorough discussion so ultimately the patient benefits. I think that's some components of a human factors approach, and I think our goal, at least at Jefferson, is to see if we can help instill that in all of our tumor boards.
Thank you so much. So now we're going to go back to Janie to demonstrate Jane Kren's case being presented at Tumor Board. And again, just as a reminder that you can submit your questions for the question and answer time that we'll have here shortly. So Janie, back to you.
Thanks, Dr. Heaney. So now that we're ready to begin Tumor Board, the moderator would choose View Presentation. It's a link in the top right corner of NAVIFY, and then the Tumor Board display will open up. The View Presentation allows for facilitation of Tumor Board and note-taking during the meeting. We have a pre-built view for the initial patient slide, which helps with standardization and improving that Tumor Board flow. From there, the summarization of the patient's journey can begin. By pinning those key elements earlier, the presenter doesn't have to rely on their memory, but they can share facts succinctly and allow for a faster facilitation of the case. As the patient's story is told, observers can see the data for themselves, and they can have a visualization of the images and the reports to have a better understanding of what they might recommend. Including a summarization of the tumor information slide assures that observers are on the same page, and it reminds them of the facts of the case. After the facts are given and reviewed, discussion regarding potential clinical trials can follow. If necessary, a publication can be shared to highlight specific elements that might make this case different from others. And finally, referring to specific guidelines is helpful to ensure that the approach is consistent with what other experts have recommended. Additional slides can be used to remind the presenter of what questions they wanted to review with the tumor board and ensure that they have all the information they need when they discuss the recommendations with the patient. Next steps is a feature that's used to create and document the recommendations received during the discussion. And here is where users can update staging information, guidelines, or clinical trials. Next steps are saved as part of Tumor Board and can be integrated back into your EMR as per your institution guidelines. After all the questions are answered for this patient, you can move on to the next patient. Now let's return to the panel.
Thank you again, Janie. So, Dr. Hammer, when it comes to maintaining accreditation, you mentioned this, that your breast tumor board is accredited. What's the importance of documentation, follow-ups, and next steps?
So as you mentioned, running a cancer center and tumor boards, there's many levels of accreditation and documentation we need to do. Such as Commission on Cancer, American College of Surgeons. All of them have requirements and quality measures that we need to submit to document we're doing the best practices. So the usefulness of having something like a clinical decision support software can help us satisfy some of these accreditation requirements. We submit a lot of data to the Joint Commission on Cancer on a yearly basis. The tumor boards are required to discuss clinical trials. So the clinical app feature in NAVIFY is a useful thing. We're also required to discuss NCCN guidelines, whether they're followed or not, for whatever reason. We do need to discuss them and acknowledge sort of the standard of care there. And then a last and maybe most important thing is to be able to track what we decide in a tumor board and follow up on the decisions that are made and make sure they're implemented. One of the things we've seen in some of our tumor boards is not every tumor board was really good at documenting the decisions and putting that into the medical record. Now with NAVIFY, we have the next steps page where we can fill out the discussion in the tumor board and the plan to move forward, and then that will actually integrate with the EMR and flow back into the patient's medical record in our main EMR, and then we can make sure that those steps are followed up on.
Yeah, great insight. Thank you. So, Dr. Dicker, when we think about the future of virtual care or telemedicine, in your opinion, how will things be different in the oncology space? How will we look at metrics or key performance indicators, and what do you see continuing to evolve in terms of virtual approach?
So just to add some color to what Dr. Hammer mentioned. So a lot of things that regarding the various accreditation agencies, what we ultimately want to see is improved clinical decision making, more coordinated patient care, more evidence-based treatment decisions, improved timeliness of tests or treatments, increase in proportion of patients being considered for clinical trials, an overall improvement in the quality of treatment. I think for the future, we'd like to see improved patient involvement in treatment decisions, sometimes called shared decision making. I think, what we would like the summation of everything I've just described to ultimately result in improved survival rates and improved quality of care. I think we've learned how to transition very quickly in the virtual world. I think the ability to conduct clinical trials in a virtual or decentralized way is going to happen shortly. And in the words of my boss, Steve Klasko, our president and CEO, this is healthcare's Amazon moment. If you're a provider and you think you're going to go back to the way the previous models were, I think that's not going to be the same. I think if you're an insurer and you're just a middle individual between hospital and the patient, I think that's going to change. I think hospitals who think that innovation is something that is left to a department is going to change as well, because medicine has been significantly disrupted by COVID-19, and the genie is not being put back into you can't put the genie back in the bottle, and all of us are going to have to figure out, from whatever respective specialty and aspect of cancer care we're involved with, how we need to change to ultimately provide high quality, efficient care.
Excellent, excellent. I am excited about what the future holds in that perspective. Okay, so now we have some time for question and answer. We have had quite a few come in from our audience, so many thanks for that. This first question actually goes to you, Janie, in terms of the NAVIFY Tumor Board solution. So can data fields be customized? And if a facility or institution would like to have additional data collected on a patient, can that field be added as an option?
So I'll just remind everybody that I'm a nurse with a little bit of experience in technical experience. And so when we integrate, as I had said before, we call ourselves agnostic, meaning we can integrate with nearly every EMR. And so it really depends on where data is kept in your EMR. And we have technical consultants who work with your team, your IT team, to help find the best way to capture those data elements and make sure it works best for your site. So if the data is there, we can help you to find it. I think that that's probably my best answer, being that I'm a nurse and not a technical consultant.
Great, great. So another question, and I think Dr. Hammer, you could probably give some insight into this one. It's when implementing NAVIFY in your institution, what is involved in terms of integration into your EMR? I know you all have done that at University of Missouri, so maybe some insight into that. And Janie, I'm sure you could probably add some too, but I think it's good to hear from two different perspectives. So Dr. Hammer, if you'd like to go first.
Sure, actually. So when we actually implemented NAVIFY, we actually did a totally manual version and then began working on the integration with the EMR. So there is actually a technical team of engineers and IT people on Roche that actually work with our IT people here. The Roche team does the bulk of the work, at least probably 90% or better, in essentially mapping the fields that we want to integrate into NAVIFY. And so again, it involves looking for structured data fields that are available in the EMR and mapping them to NAVIFY. So when we started, our integration process started in October of 2018. And we now have integrated things like patient demographics, pathology reports, radiology reports, and radiology images. So all we have to do now for us to get a patient into NAVIFY is we enter an order in our EMR, just like a physician would enter any other order for a lab test or anything else. And we say, you know, Jane Kren needs to be presented at Tumor Board. And that automatically populates all the integrated data into NAVIFY, and we don't have to do anything else manually to do that. Once the data is in there, we just go in and pin the selected data we want to put in our presentation, and then the software actually creates the presentation by itself. So that's a process, though, and of course the Roche team will work with the institution that is integrating, depending on what their EMR is, and make that happen.
And I would echo that. Everything is accurate. It takes us about 6 to 9 months to do an integration. And one additional thing that we do while we're working on integration is we evaluate workflow. And sometimes we can save you some steps. We find that sometimes people are repeating the same information or repeating the same tasks. And sometimes we can reduce that just by you know, observing and making those recommendations.
Excellent. Okay, so Dr. Digger, this one is for you. And we talked about a little bit about, you know, how we're not going to go back. And in the past, resources for novel technologies like digital solutions in healthcare haven't always been a priority for some health systems. How, you know, you commented a little bit on this already, but how do you see this changing in the future in terms of oncology and digital solutions to provide clinical decision support?
Right. So I think it depends, you know, every stakeholder, providers, patients, caregivers, healthcare systems, you know, third-party payers, everyone has a different ROI on that equation. I can't anticipate, you know, every healthcare system took a major hit in the past 3 months, and you know, unfortunately, in many locations around the country, there have been furloughs or people have been fired. I think you're going to see consolidation in healthcare, at least in the United States. So we need to figure out more effective ways to deliver the same care, if not better care. And I think clinical decision supports are one of them. On a personal level, what happened to me over the past 3 months is I went into cognitive overload. First of all, my nights and days became one as I was responsible for delivering healthcare. We never closed, right, in terms of just like Dr. Hammer's department never closed during COVID-19. So, you know, one, we were trying to come up to speed. You know, I have a WhatsApp group of oncologists that's worldwide. The conventional sources of medical information, there was a lag in terms of learning from people in New York or people in Italy or people in Israel or elsewhere. So that was contributing to the cognitive overload. There was cognitive overload, you know, being concerned, Dr. Hammer and I, with our staff, and how do we rotate staff, and who comes in and who doesn't come in, and how do we deal with that? And then there's the what do we counsel our patients, and other aspects of delivering cancer care. So I think the cognitive overload really emphasized for me how clinical decision supports systems and curating and in some ways and quality information and automating some of these processes have become even more important during this time, not less important. So I think, and the ultimate goal is indicated by Dr. Hammer's research vis-a-vis the nurse navigator is ultimately to increase the amount of empathy and time we have with our patients, not decrease it. So I do see, I think how we evaluate ROI will change. But there's not going to be more resources to deliver care. There's only going to be less.
Mm-hmm. Excellent, excellent. Thank you. So, okay, so another question in terms of NAVIFY Tumor Board solutions. So, Janie, I'll hand this one to you. So, with those that attend Tumor Board, they're able to log in to the Tumor Board content and participate. And is there a way to look at attendance records for those that do that?
So yes, there is. The attendees are recorded, and so you can look back on that by looking at past tumor boards. So just by clicking on a past tumor board, you can see who attended.
Excellent. Okay, and then maybe a little bit about, and I can speak to this as well, but maybe Janie, if you want to take it first, and then I can add to it. Is it, in terms of future applications that will be implemented into NAVIFY Tumor Board, what do those look like, and how does, clinical decision support approach?
So, right now we have the 3 apps, and we're looking at others, and we're always interested in, what other ideas people might have. Specifically for guidelines, I'll just talk about that. Right now we have NCCN guidelines, but we do, I'll just say we're working on, but it's very, very close, and it may be implemented and I'm just not aware of it. But you can implement your own internal guidelines. So if you have your own guidelines or recommendations for patients that follow your formularies and your physician recommendations, then those can also be included.
Excellent. So we, just generally speaking, we are working on building, our own apps, but we're also interested in co-developing apps with partners. And so one of the things that we've also been going towards in terms of clinical decision support is a focus of being able to compare a particular patient with a population of patients similar to that patient. And that is something that's currently in development and that we're looking to further develop as a clinical decision support tool. I mean, I want to just kind of leave it there because it's not fully vetted out, but essentially it will be able to look at that individual patient and compare it to other patients that are similar to that patient and be able to show how those other patients were managed from a patient care perspective and give some clinical decision support to the healthcare provider or the multidisciplinary team looking at that patient. So that'll give you an idea of some of the applications that we're looking to add in terms of clinical decision support. Okay, so one additional question. So Dr. Hammer, this one is, since you've implemented NAVIFY Tumor Board solution at your institution, when you started utilizing this solution virtually, what challenges did you see? Was it solution related? Was it attendance related? What are some of those challenges that you saw, and how did you all overcome some of those challenges? And I think Dr. Dicker, you probably could address this too, but let's start with Dr. Hammer.
So that's a good question, because I was a little naive maybe, but I thought it would be very seamless, and it was seamless from a NAVIFY and a tumor board preparation aspect. We did essentially the exact same thing. But one of the challenges we had when we went to a virtual environment is that many of our attendees are not very computer savvy, and so they actually had more issues with using the platform we were using Zoom, in how to actually just function within a teleconference. So they didn't understand about how to sign in on the audio or use the right buttons. And so we needed to do a little education on that. And that quickly resolved after that. The other thing that is something to consider is sort of the hardware that you're using at your institution. Because one of the things we found is not everybody has a camera, not everybody has a microphone hooked up to their computer. And so that was another issue that everybody had to get up to speed on. But once we solved some of those problems with education and how to use the platform, and then some basic hardware issues like let's put a microphone on your computer so that you can talk through your computer rather than call in through the phone. Those quickly went away in a few weeks, and now everybody's very comfortable now using a virtual environment, just as if they were in a room.
Excellent. So Dr. Dicker, any additional comments?
Yeah, again, healthcare systems generally are not run like technology companies that have teams, virtual throughout the world. So there is a learning curve. Many of us have been using Zoom for a number of years. Again, it's one of a number of, webinar, video conferencing platforms. As we saw the pandemic start to take hold, we bought another 7,500 licenses on Zoom. It's fascinating how most people don't appreciate all the functionality that Dr. Hammer mentioned. You can avoid the chime, you can have mute as a default. I think encouraging people to use the camera so you can read the body language is always helpful. So I think there's a bit of etiquette and learning curve with these sort of things. It doesn't normally get covered in medical school, although all medical schools throughout the United States, at least for the first year students, have had to move to a virtual teaching environment, as well as many universities. So there is a learning curve. I think you just have to expect that. I see more on my desktop monitor in terms of the pathology and the radiology sometimes than when I attended in person, certainly higher resolution. So I think there are some advantages towards a distributed platform.
Very nice. So we have time for one last question, and this is like broader in scope, and I think it would be great to hear from both Dr. Hammer and Dr. Dicker on this. So let's go with Dr. Hammer first. But we've talked about standardization, between multidisciplinary care team meetings, and we know that that doesn't necessarily always happen. We also know that it's not the same between institution to institution, and because of that, some of that may be the expertise that one might have at a larger academic medical center versus a smaller community center. So I'm just wondering if, as we go into this telehealth virtual space, do you feel that there will be opportunities to pull that expertise virtually from other areas to continue to provide the optimal care? Because I know during some of our discussion, you have mentioned that it might even be better from a virtual approach for the patient. So I'm just curious to how you all see that part changing in the future.
Well, I would agree. Actually, there's a lot of application and a lot of potential for doing virtual tumor boards. We're actually, University of Missouri is a rural-based university, and then we have a lot of affiliates that are smaller rural hospitals. We were actually on the road to implement virtual tumor boards at some of our smaller hospitals that might be nearby, and by nearby I mean in the next city, not necessarily within Columbia. So yes, this is a great resource and a great platform to be able to extend a center of excellence or expertise to a more community-based outreach and provide support on a maybe expert level to community physicians or tumor boards done in smaller hospitals that don't have necessarily all the same resources. So from a rural perspective here, and I'll let Dr. Dicker speak to his side, which is a bigger multi-site institution, we totally are looking forward to implement this across the spectrum of different size hospitals that we work with.
Yeah, I mean, I completely concur with Dr. Hammer. I think that, again, the words of my boss, Steve Klasko, technology can close the gap between the haves and the have-nots, but you have to be strategic. I think what clinical decision support systems like NAVIFY do is allows you to really to democratize and push out this technology, because now zip codes and distance really have no meaning. I think it allows us to bring in different types of data streams. Social determinants of health are an incredibly important, although not many people have really figured out how does it factor into decision making. So I think that's something that needs to be worked on. The ability to pull in expert opinions that may not be within your particular healthcare system, have a nationwide tumor board for more vaccine challenging cases is now certainly possible. I think wearables and other types of data that cancer patients may be bringing, whether it's patient-reported outcomes or wearable technology, is another thing that allows you to level the playing field and ultimately, reduce the type of disparities that we see across America and as it relates to cancer care.
Great, thank you both for your insights. Really appreciate that. So I know Janie wanted to close up the demo side of things and talk a little bit more about NAVIFY Tumor Board Solutions. So I'll pass it over to you, Janie, and then we'll wrap it up from here.
Thanks, Dr. Heaney. And I also want to thank Dr. Dicker and Dr. Hammer. The importance of virtual care and virtual tumor boards is more critical now and during this time to continue to care for patients. We are currently offering the use of NAVIFY Tumor Board at no charge for the next 3 months for you and your institution. This will give you and your care team the time to use NAVIFY Tumor Board to conduct your virtual and on-site tumor boards. You will receive a follow-up email from the webinar with a link to sign up, or you can learn more. Thanks, Denise.
Great, excellent. So thank you everyone for attending today. We really appreciate the time. Thank you to our panel for sharing your expertise with us, and to Janie for providing us with an overview of NAVIFY Tumor Board Solution. During this pandemic, we really have witnessed a rapid transformation to virtual care for many areas of healthcare, including oncology. And we know that the benefits of the virtual approach are recognized daily, and to Dr. Dicker's comment, will become a new normal in healthcare. You will, as Janie mentioned, be receiving an email after the webinar. We'll have several pieces of information. In the event that you had posted a question and we didn't get it to us, please feel free to reply and get those questions to us, and we'll get a response back to you. Again, we appreciate your time today and hope that everyone stays safe and healthy. Many thanks.